welcome them in advance and welcome all dear students who have joined. I request them to have interaction with this. I again welcome Ritu from Pushpagiri Medical College, final year students. She's going to present and have a discussion with us for another 1.5 hours. Welcome Ritu, over to you. And without wasting much time, I welcome everybody to have a good interaction with us with the discussion. Over to Ritu for a presentation. So PPT. Thank you very much. Shreya PPT.
Good evening, everyone. So today I'm going to be by his wife since 2 months, which is also seen associated with loss of appetite. The patient also complains of frequent episodes of fever, which was low grade in nature, intermittent type, not associated with any chills or rigor. No history of any pain associated with the swelling. No history of any nausea, vomiting, or abdominal pain. No history of chronic constipation or altered bowel habits. No history of abdominal distension, hematemesis, or melena. No history of chronic cough or evening rise of temperature. No history of any other swellings in the body. No history of yellowish discoloration of eyes. No history of any trauma to the abdomen. No history of any hematuria or dysuria. No history of any bone pain. No history of any breathlessness or chest pain. Past medical history. No history of hypertension, diabetes mellitus or dyslipidemia. No history of tuberculosis or asthma. No history of any blood transfusions. Past surgical history. No history of any previous surgeries. Family history. There is no history of any malignancy in the family. Personal history. The patient consumes mixed diet, has reduced appetite, adequate sleep, he has regular bowel and bladder habits, no history of any allergies, no history of any smoking or alcohol consumption. Summary. 23-year-old gentleman presented to the OPD with complaints of a painless swelling, insidious in onset, noticed on the left upper quadrant of the abdomen of size of about 4-finger breadth. He also complains of a painless swelling in the left supraclavicular region with the size of 2-finger breadth. He also mentions of frequent episodes of low-grade intermittent fever, weight loss, and loss of appetite.
Wait, we'll go for history. Chief complaint. Shreya, go back. Shreya, go back to history. History, chief complaint. First slide. Right. Chief complaint. Why this fever is there? No, should they mentioned in the chief complaint? I think, and loss of weight also there. It's quite very important to suggest. May suggest something more, or it may give us some additional thing. I think. Okay. Next slide, Shreya. Their swelling was incidence noted first noted by swelling gradually from 1-finger breadth to the size to 4-finger breadth. You mentioned clearly, is it 1-finger breadth and 4-finger breadth like that, or
He said it was somewhat about one finger breadth.
Okay. Okay. Loss of weight by the wife. Okay. Loss of appetite also. So next slide. Frequent with fever, which was low grade in nature, intermittent, not with any chills and rigors. Okay. What it means for you?
Sir, chills and rigor is mainly seen in high grade fever, pointing to any malaria or any other infectious pathologies.
But since how long this fever is there? You have not mentioned whether it is there since 2
He
months or
says he's been having it since about 4 5 months. He's having this on and off fever pattern.
the fever has started first and then swelling, is it? Mass or swelling?
Sir,
What has
he didn't specify about that. He said he has been having fever on and off.
okay. It means the fever has come. That's what because the duration of the fever is important. When it has started, how severe it is, that things are also important. So next slide. Yeah, next slide. Right, sir. Manohar, sir, you will add on to some histories, this thing, then we'll go to Robin, then go into.
I agree, sir, that the history of fever and other things should have come in the first slide itself because
Yes, sir.
it correlates.
Yes, sir. It's important actually in the next spelling and
And next one, and the other points
fever
are what she
is
said.
very important. Its duration is important. Its detail is important.
Yes,
I
yes.
think. Okay. Pain, nausea, vomiting, chronic constipation, abdominal distension, hematemesis, melena. Why hematemesis and melena? You wanted to ask, keeping what in mind?
Sir, to point out any, to rule out any liver pathologies, portal hypertension,
Okay. Why
because
hematemesis occurs? How hematemesis occurs in portal hypertension?
So,
due to
Due to
various
Relevant to this case, you have a left hypochondrial mass and the patient presents with abdominal distension, left hypochondrial mass, two, hematemesis or melena. What is the relevance? What is the cause? Differential diagnosis there. Just one word answer, that's all.
Sir, can you repeat the question once more?
You have a left hypochondrial mass. The patient presents clinical examination or complaints abdominal distension. The patient also has hematemesis or melena. What is the cause for the hematemesis?
you said
Uh,
liver.
va-
You said liver.
yes, sir. Esophageal varices.
Very good.
Esophageal varices could be the reason for hematemesis. Can you please tell us how it happens? What is the reason for it?
Sir, increase in case of portal hypertension, there is increased pressure, so that can lead
Yes, that's
collapse.
all. No, don't explain. That's all. That's it. Portal hypertension is the reason for it. Can you be very specific? What type of portal hypertension can result in a left hypochondrial mass with hematemesis?
Um,
Think and answer. Just what type of portal hypertension? There is a name to that sort of hypertension.
only 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 spleen is enlarged. No ascites, suppose. What type of hypertension will cause these things? Just it's a leading question. Professor Robin is asking. Will you able to answer or not? It's okay if you not answer. We'll answer it later. Okay.
so,
Ritu?
Just because you said it, so it is not a very undergraduate question, but it is called left-sided portal hypertension, also known as sinistral hypertension.
Also called as segmental portal hypertension. Left side
Segment
sinistral
hypertension.
hypertension. It is. It's localized. Okay. Now you wrote no evening rise of temperature. You said there is fever, and why you are specifically it is often very difficult to uh,
that is
correlate.
to rule out tuberculosis.
Yeah, it is not necessary to have a only evening rise of temperature, no other type of fever in tuberculosis and this one. So if there is a fever, better to avoid such a thing, I think. Okay.
Okay, sir.
No any other swelling in the body. Okay, yellowish discoloration of eyes. Why yellowish discoloration of eyes?
To rule out jaundice, in case of any hemolytic anemias, jaundice may be seen.
Okay. Trauma. Why you wanted to ask a trauma to the abdomen in this patient?
Sir, if there
Ask.
is, it's the left upper quadrant, so trauma can result in splenic ruptures or any
Is
organ
which is
damage.
the
This one.
most common area for blunt trauma abdomen? No, see when you ask when you say negative history, It should be relevant to your case. That is what sir was asking. Well, if you have a left hypochondrial, so what he's trying to ask is it possible that a trauma can cause a left hypochondrial mass, a big left hypochondrial mass?
In case of any splenic trauma, it can result in subscapular hematoma.
And if there's a
And
capsular hematoma, the patient will walk around for so long.
It will last
no,
for
sir.
6 months like this, and you'll have a happy event like that. And hematuria and dysuria, why?
To rule out any malignancy regarding the kidney, renal cell,
Mass. Why constipation and altered bowel habits?
to rule out any malignancy regarding the colon.
Colonic mass, whether we'll seek malignancy or not, we can discuss colonic pathology. Okay. Bone pain, why bone pain?
In case of any myeloproliferative diseases, bone pain can metastasis also can produce bone pain.
Why specific? Why you want to think of myeloproliferative disorders like this? Okay, specific. You can give a specific, simple answer, no?
Sir, here the patient is presenting with loss of weight and loss of appetite also, and there is a mass. So, in case if it's any malignancy, to see if there is any spread or metastasis to other parts of the body.
Okay, okay. Breathless and chest pain for the same reason or any other reason in the patient?
Same reason, sir.
Same reason. No other reason you will think of. I'm just asking.
Uh,
Okay. Okay, next slide.
Dr. Thomas, you said just because you said no history of breathlessness, chest thing, and bony pain, and you yourself said it is because of
Go back.
metastasis. Yes,
yes, sir.
agreed. May I ask? Yeah,
Uh,
what metastasis is common to spleen? It is a very obscure
Malic-
organ, so we're hiding somewhere behind the ribs. So is it
malignant melanoma?
is neoplasm very common to spleen?
No, sir.
In what condition splenomegaly with the fever, with the bone pain, which condition will think of?
Sir, it's not clear.
No, splenomegaly with the bone pain, with the fever, with the loss of weight, which condition you will think of? You said you can have neck mass also. Say, go back. Keshav, you got anything to question? Keshav will go to Keshav.
No, that is what, sir. I think students, they should concentrate on the timing of fever with respect to the mass is also important. See, in the inflammatory process, probably the fever is first, and then the mass comes. When there is an abscess formation or something of that sort. Whereas if you are thinking in terms of a chronic disease, the fever may be incidental or maybe coming a lot later. The mass will be first and the fever may be later. Suppose there's a tumor or some tumor necrosis can give rise to fever. Whereas if it's an inflammatory mass, the fever probably precedes the mass. So that timing is very important.
Let's say orderly wise, you should come in the chief complaint. That's important. I
And
think.
we should think in terms because it's a young patient, he's a 23-year-old patient. So directly thinking about metastasis and uncommon malignancies is little difficult. 23 is almost the same age as any medical student. So we should think of, yeah.
Right, absolutely right. So next slide, Shreya. So past medical history, you have discussed, no, you told, no, already. Past history,
Yes.
hypertension, diabetes. This why dyslipidemia you have specifically in this patient, 23-year-old person. What in this your current clinical scenario? Why you are interested in asking very specifically dyslipidemia, or it is a routine question which you wanted to ask? I'm just asking.
Routine could be because of the lifestyle habits in case if there is any.
Okay, is overweight? Is it obese? Is
No, sir, he's not overweight.
no history of tuberculosis, asthma, no history of any blood. Why blood transfusions you are interested in this patient?
Sir, if there has been any episodes of anemia, severe anemia, so blood transfusions were required or not.
Okay, okay. Or might have had this one, maybe related to the disease itself, might have as part of the treatment. Okay. No history of any previous surgeries. Okay, right. Next slide. Say next slide. Family history. Why family history relevant in this patient? Put the family tree. That's good. Very definitely. I've been telling students put a family tree since every live sessions. I think Robin sir also pressing so much earlier sessions. Family tree you have to put now. Of course, they are putting it's important. So why family history is important in such patient? What
Sir,
keeping
there are
what condition you are keeping in mind in relation to the family as such in this patient?
mm,
I'm just
so
asking.
there are conditions like Gaucher's disease, etc.
Gaucher's is a familial problem, or is it a metabolic storage disorder?
It's a metabolic storage disorder.
Does it run in the family?
It is not.
We are talking about family history. You specifically said about malignancy. What Sir has asked. Which is the most common malignancy that you will see in the spleen? Neoplasm. Neoplasm are of two types, benign, malignant. Which is the
Benign and
most common benign that you will see? Which is the most common malignant you will see? That's all.
benign hemangioma is the most common.
Hemangioma, that's it. Malignant variety?
Liposarcoma.
Liposarcoma, spleen.
Malignancy of what? Spleen.
Fibrosa.
A
Fibrosa.
malignancy. Not we are not talking about a primary malignancy of the spleen. Spleen is involvement in a neoplastic condition, which probably you would have thought of a diagnosis in this patient.
Spleen is a part of what
I-
system?
In the part of the which system?
What system is it part of?
Reticular endothelial system.
Reticular. So what comes there? What is the common malignancy?
Lymphosarcoma.
Huh?
Sir, lymph nodes.
Lymph node. That's what condition? Primary
Lymphomas.
lymphoma. That's what lymphoma may run in family, no? Same thing holds good. Thought pain in young individual. Probably possibility you have to think of. The primary malignancy is very uncommon. Even secondary in the spleen is almost unknown or academic interest. Clinically, may not say it is secondary in the spleen. Primary may
So
occur secondary again.
she had mentioned about secondaries in spleen. Just for our sake and for the students listening, can you give us two conditions, just two areas of the body? One is not very common, second is very common. That's the only clue we can give you. Primary is somewhere, metastasis is in the spleen.
Sir, malignant melanoma.
One is malignant melanoma. Second one, most common melanoma. Second, I gave a clue. It is very common, more common than malignant melanoma. Something that you see almost every day in the OPD ward, in the OT. Obviously, we're talking about a malignancy. CA breast. There are two. There are others. Is at least remember two. Whenever it's like what Sir was asking. Be very careful when you mention something. Be ready to back it up. That's all. Primary, benign neoplasm, malignant neoplasm, and familial. What is the thing? That's it. It's very simple. Spleen is a very small chapter. It's not very difficult.
That is important. Yeah, that's important. Detail history you are taken very nice, and you should be able to give reason why you want to take, and what things, what conditions you are keeping in mind. Whenever you ask any words, any sentence, when you tell any history, you should have something in your back of mind to give reason. So you should be able to reason. So reasoning is important for every word, whatever you present. That is all. That's what exactly I think Professor Manoharan, Robin, and Keshav Prasad actually expressed. Okay. So next slide, Treya. So he said reduced appetite, adequate sleep, regular bowel habit. How much weight he has lost? He has told, is it?
So that he has not specified. His wife said his clothes are very loose.
Okay.
They have
Now,
become very loose.
what is that general example you might have checked? Okay. Next slide. Okay. Summary. You said about 4-finger breath, complaint, plainness, swelling the left region. The size of finger breath. Okay, you can tell size, approximate size. You will tell, no? Finger breath. Multiple frequent with low grade. Mention frequent with low grade, intermediate fever, weight loss, and loss of appetite. Okay, next slide. Okay, so that is the mass. Okay. Okay, next slide. Okay, present Ritu. Sir, Robin, sir, Manoharan sir, let us start present the general examination, I think.
Yes, sir. Yes, sir. Proceed, sir. Please proceed. Yes, sir.
Ritu, continue.
General physical examination. The patient is conscious, cooperative, and well oriented to time, place, and person. He has a height of 160 centimeters, weight of 55 kilograms, BMI 21.5 kilogram per meter square. He is thin built and poorly nourished. Spine and gait normal. Pallor is present. Left supraclavicular lymph nodes are palpable. No icterus, cyanosis, clubbing, or edema. Vital signs: temperature 98.4 degree Fahrenheit, pulse 75 beats per minute, normal rate, regular rhythm, normal volume and character and condition of the vessel wall, respiratory rate 20 breaths per minute, blood pressure 120 over 80 millimeters of mercury in right upper arm in sitting position and with the adult cup size. Examination of the abdomen. The patient was examined in a well-lit room after obtaining consent. Examined in sitting position and supine position with hips and knees in flexed position. Chest and abdomen was exposed. Inspection. Abdominal fullness was present over the left upper quadrant. Umbilicus central and everted. A swelling of approximately 6 into 6 centimeters size seen occupying the left hypochondrium just below the left costal margin and moves with respiration. The skin over the swelling appears to be normal. No visible peristalsis or pulsations. No visible scars, dilated veins, or any skin discoloration. All hernial orifices appear to be normal. Palpation. No local rise of temperature or tenderness present at the left hypochondrium. Single ovoid mass measuring 6 into 7 centimeters is felt just below the left costal margin, extending towards the umbilical region. It is smooth surfaced, notch present over the anterior surface, sharp edges and firm in consistency. The swelling moves with respiration with no intrinsic mobility. The fingers cannot be insinuated between the swelling and the left costal margin. No pulsations felt over the swelling. Palpation of liver not palpable. Palpation of kidney not palpable. Palpation of hernial orifices. All hernial orifices are normal. Examination of lymph nodes. Left-sided supraclavicular lymph nodes were seen to be enlarged. Percussion. Dull note over the left hypochondrial region extending from the 9th rib and continuous with the swelling with no tympanic note in between. No shifting dullness. Liver dullness at the right 5th intercostal space. Auscultation. Normal bowel sounds heard. No bruit. Examination of external genitalia normal. Per rectal examination is not done. Examination of swelling in the supraclavicular region. Inspection. Swelling on the left supraclavicular region of size approximately 3 into 2 centimeters. It has smooth surface. Skin over the swelling appears normal. Surrounding area normal. No scars, dilated veins or sinuses. Palpation. No local rise of temperature or tenderness. A swelling of size 3 into 2 centimeters is present on the left supraclavicular region. Spherical in shape, rubbery in consistency and not matted. It is mobile in nature with no fixity to the skin, no fluctuation, no other palpable lymph nodes present. Systemic examination. Respiratory system. Normal vesicular breath sounds heard over the lung fields, no added sounds. Cardiovascular system. S1, S2 heard, no murmurs. Central nervous system. No focal neurological deficits. Sensory system normal. Summary. 23-year-old gentleman presented to the OPD with complaints of a painless swelling, insidious in onset, noticed on the left upper quadrant of the abdomen of size of about 4-finger breadth. He also complains of a painless swelling in the left supraclavicular region with the size of 2-finger breadth. He also mentions of frequent episodes of low-grade intermittent fever, weight loss and loss of appetite. On examination, pallor is seen, left hypochondrial fullness suggestive of non-tender splenomegaly is seen, along with palpable left supraclavicular lymph nodes. Provisional diagnosis. This is a case of left hypochondrial mass suggestive of enlarged spleen associated with the palpable left supraclavicular lymph nodes, probably a case of lymphoma.
What type of lymphoma you thought?
Sir, I'm thinking about Hodgkin's lymphoma.
Okay. We'll talk about later why it is. So you go for, say, we go for the examination inspection. How you have inspected the abdomen? Which all positions you have used while inspecting the abdomen? Say, go back to the inspection slide. Which all position so you have used to inspect the abdomen, Ritu?
In supine position,
Okay.
um,
So by which side you have inspected?
left side of the patient.
Okay. Usually we'll examine the abdomen left side or right side.
We will be standing at the right side, and the area of concern is to be examined, palpated at last.
From additionally where else you will stand and inspect the abdomen
Um,
other than the right side.
Sorry, left side, in case of splenic examination, left side can be.
As for palpation, you will go to and do the palpation. Many times you are allowed to do palpation on the left side for the spleen and left kidney. That for spleen initially always again in the right side. Only when you want to confirm additional findings as far as spleen is concerned, then go to the left side. Otherwise, from the right side only. Inspection you have to do from the foot end also, right side and foot end, both areas. Okay. And fullness, you said it mostly the respiration. You said skin over the swelling is normal, no peristalsis, no pulsations, no scar, no dilated vein, any scar, discoloration. All those things you have mentioned on inspection. Dilated means how you look for?
So dilated means if it's around the umbilicus with two fingers.
So how you inspected in which position?
Inspection, not palpation. Inspection. No two fingers. What finger? How did you figure out dilated veins? Is the question. Dilated or engorged veins in
What will you
inspection?
do? For dilated veins in the abdomen, what position you will use to do inspection? So only simple question, clinical question I'm asking. I'm not asking anything extra question. Not no hitch in the question. How you will inspect the abdomen or dilated veins? What position you will make the patient? In lying down, sitting position, standing position.
Standing position.
Always standing position. Okay, standing position in front and from the side you have to inspect. Okay, okay, great. So impression. Anything else to add, sir? Manoharan sir, Keshav, Robin.
No, the extent has to be mentioned, I think, because if you imagine we are sitting here, you are telling only 6 into 6, but the extent from the midline.
Yeah, that's absolutely right because it is not just fullness. There are two words you can use on inspection. When measure mass is because your photo you have seen mass is visible.
Whether all the borders are visible also is very important.
Right. When you say fullness, fullness is when it is not clear. Then you will use the word fullness. Here, like Keshav is rightly told, we have not seen the patient. You have seen, maybe Robin might have seen, but your photo itself is the clear, visible mass actually. It is very obviously visible. So such situation tell the mass is visible.
This is visible.
Order is like this. It moves with the respiration. So straight away you can tell findings as a mass. It is a visible mass. Fullness, when it is not clear, then you say use the word fullness. I think, sir. I think it should be okay. I think, sir. Robin and Manohar, because here your photo we have seen that just we are not examined, but it looks very nicely actually. Visible mass in the left hypochondrial, very clear. So in such a situation, you can tell the mass. When it is indistinct, then you tell fullness is okay. Even then you can tell approximately extent of for whether it is crossing the umbilicus. Because when you say spleen, usually whether it goes towards which direction it goes towards the right iliac fossa, then across the umbilicus, how far umbilicus one position, and moves well with the respiration or not. So those things you should be very more specific, very clear about these things. I think.
Any notch is visible.
Any
On
visible
inspection, what else you have? What else do you look for? You are suspecting a left hypochondrial mass. What else will you look for?
If the mass is moving with respiration.
That you already said. No, what is missing in your slide? Manoharan Sir said by mistake, but you did not catch it.
Sir, other.
That is why quickly I interjected. What else is missing? You have a mass in the abdominal fullness, like sir has already specified. It's the whole thing. It's diffuse. No, it's quite clear from where to where extent is missing. See, I don't know what is very difficult in. You're giving exam. site of the swelling. Any swelling, the same thing. Skin over the swelling, site, size, shape, surface, number of swelling, extent of margin. It goes like 1, 2, 3, 4, 5, 6. It's so easy, right? There's no difference in that for any swelling in anywhere in the body. So exactly what Keshav sir had pointed out, without extent, what's the whole point? Because when it comes to differential diagnosis of now what you said, it is a splenomegaly. There are different types of splenomegaly. There's mild, moderate, severe. And in surgery, what are you concerned with? What are you concerned with in surgery? Which type?
Massive splenomegaly.
Massive splenomegaly, also known as surgical splenomegaly. In that, don't you think the extent is important?
Yes, sir.
Because the causes are different for each of them. Causes are different.
And all those features will help you to say this is mass is spleen.
Yes.
So
what is the classic characteristic feature of a spleen which sir said you... Why didn't you mention that here on inspection? It's quite a big swelling. So where do you find the notches on inspection classically?
Anterior border of the spleen.
Yes.
Anterior border of the spleen. How many notches will you look for in the anterior border, or anatomically speaking, the medial border?
Medial border.
When you read anatomy, it's very beautifully written. When it's growing, it's usually seen in the middle, but when it grows down, when you palpate, it's on the anterior portion that you see this. Yes. How many notches do you expect to see?
Sir, Manohar sir, you wanted to ask some questions, sir.
No, sir, direction of movement, you pointed out already.
Yes, sir.
Movement with respiration, you said. The spleen direction is unique. Which direction does it move? Towards?
Right iliac fossa.
That you should mention, no?
Specifically, you have to mention which direction it is moving.
Notch and direction of movement is specifying spleen. Understand?
Okay, sir. And flanks full or not, you have to mention, especially when you think it is a spleen. On inspection, fullness in the flank may suggest free fluid. That is very important. That the spleen is considered. Understood? So flanks full or not, you have to mention. Okay. So next slide, Shreya.
Sir had asked what are the positions in which you will examine this patient, a left hypochondrial. So sitting, lying down, standing, everything. But is there any other position that you can? Any other position to examine this patient?
Sitting, lying, standing.
Anything else?
Any other position?
So in case we are suspecting any ascites.
No,
not ascites.
That's a percussion, you are telling, not palpation. Robin is asking palpation.
Is there any other type of examination which can help you to differentiate the swelling from something else? Because differential diagnosis of anything in the abdomen, there are two parts of the abdomen. We cannot give you more clues than this.
Sir, to differentiate whether it is a parietal swelling or an intra-abdominal swelling?
So if it's a parietal swelling, it's quite obvious it is arising from the skin. You have said that it is not in the skin. Now that we have already said, there's nothing else to suggest that. We are talking something else. What about intra-abdominal? What else is there in intra-abdomen? We are saying it is not spleen.
You actually mentioned it in in the slide, but there's another method to examine that. In this slide itself, it is there.
Finger insinuation between the swelling.
Yeah, so extension of that only. So what else? How else will you palpate for to know whether the mass is arising from spleen or from some other visceral organ? What is that method where you stand on the left side of the patient?
Middleton's maneuver.
Okay, that's okay. A Middleton's manual is there. Spleen, that's why she said spleen will palpate, inspect on the left side. Palpation you can do spleen. After doing from the right side, you can confirm additional finding from the left side. Definitely. No,
there are four methods of palpating spleen. It's there in the classic. It is there in DAS also. Yeah, do you think a knee elbow position will have any significance in this case? What if it is not spleen and you have said the patient is having a left supraclavicular lymph node? There are multiple nodes and we are thinking of something else. Hodgkin's lymphoma, okay, some lymphoma, not Hodgkin's, maybe non-Hodgkin's also. Because there are gross difference, more than 10 differences between a Hodgkin's and non-Hodgkin's, classic differences. Symmetry, asymmetry, these magical words are there.
Sir, in case of we suspecting any para-aortic lymph nodes, knee
So
elbow
where this is
position,
that's a simple question. Para-aortic is lying where? Where is it lying?
to peritoneum,
In the peritoneum. Hmm.
Parallel is
behind
located intra-abdominal, retroperitoneum, midline, lateral, vertical,
midline,
horizontal. So all those things you have to be very clear about it. Above
Aorta,
the below the abdomen,
anatomically speaking, aorta is what sort of a organ? Where is it lying?
blood vessel lying on the posterior abdominal.
Retroperitoneum. How do you differentiate an intra-abdominal, that is the intra-abdominal, intraperitoneal swelling, from a retroperitoneal? That's a knee elbow position. Simple as that. What if you have lymph nodes full chain on one side and you have a small spleen? What if it will not fall forwards? No. The difference. A simple question we had asked. Okay. Sir, Keshav sir, okay.
you have done leg raising, head raising test.
Yes.
What is the test called as?
A Carnet test.
Test. Okay. Why? Because you said left supraclavicular lymph node is palpable. All those things you have already told, no? So will it be colonic mass? I'm just asking. Because you got a colon, you got a pancreas, you got a kidney there, you got adrenal there, retroperitoneal masses are there. So many structures are there in this region.
The colonic mass is more deeply placed.
Okay.
It will not be something that is achieving superficial palpation.
There is no superficial palpation in the abdomen. Palpation and deep palpation. There's nothing superficial in the abdomen, okay? There is palpation in the abdomen divided as palpation and deep palpation. It's no terminology for superficial palpation, okay?
Probably the method to describe this mass, no, you should describe the mass entirely. You are just mentioned single ovoid mass. You are not told upper border is palpable or not.
Upper body
Whether
is important, no?
whether in standing or sitting position the mass comes down. Is a little more
A
diligence
little,
can be given.
For that, but
little more descriptions are the
Description, yes.
mid-clavicular, anterior, this thing, and how many
First you tell
centimeters
that
mid-clavicular, then little laterally, how much? Because that obliqueness is seen. So it is not 6 by 7 centimeters everywhere, isn't it? You see the picture also. Mid-clavicular, maybe it is more. The right side it is less, left side is it. So if you describe the borders, you'll be able to
yes, and the border is also not mentioned.
not mention.
Whether it is smooth or firm.
Ritu, important. Remember, any upper abdomen mass like liver, stomach, spleen, upper body is very crucial. So for that, you have to make the patient to stand, sometimes make the patient to walk also. Whereas in lower abdomen mass, lower body is very crucial. Like pelvic mass, lower body filled or not, it goes into the pelvis or not. And many times you have to ask the patient to pass the urinary exam. And remember, no, upper mass, upper body is very, very crucial. We are interested. Whereas in lower abdomen mass, lower body is very crucial. You have to remember that. So any mass, for example, spleen, liver, stomach, upper body is very important. It's specifically mentioned. Okay. So because if it is felt, it is unlikely to be spleen. It may be kidney, it may be adrenal, it may be colon or something else. So that is how interpretation goes. So you won't be able to feel upper body in spleen actually. Same holds good for the liver. Okay. So finger cannot be said. She has told those things, everything. Surface is smooth, she said. Okay, agreed. Form and consistency. So we'll go to the next slide, Robin.
Yes, sir.
Yes.
Slide. Palpation of liver, palpation of kidney. Okay, this separately you want to look for the kidney in this patient. Liver is okay. Why you want to look for liver?
Can you give us any differential diagnosis where you have splenomegaly with hepatomegaly?
Often you say single word, you will tell usually student, no hepatosplenomegaly like that. So justify those technical words many times. Most of the students are fond of that word. I think, Robin.
Can you give us any condition where you have splenomegaly and palpable liver?
Malaria, infectious conditions like malaria.
Infectious conditions like malaria.
Infectious mononucleosis. Then
infectious mononucleosis.
Portal hypertension.
And anything else? Anything else? Differential diagnosis you want?
Lymphomas, leukemias.
Leukemias, acute myeloid leukemia, all the myeloid leukemia, myeloproliferative disorders. What about lymphoma?
Lymphomas, hot. In case of non.
ആലോചിച്ചിട്ട് പറ.
Mm,
Think and answer. You have
in
two
case of
types of lymphomas classically for at least this chapter of lymphatics you need to know. Hodgkin's and non-Hodgkin's.
non-Hodgkin lymphoma.
Where will you find?
Hodgkin's lymphoma, a small percentage in case of
No,
Hodgkin's
you
lymphoma,
cannot say.
there
If you say small percentage, then we will ask you what is the percentage. Yes or no, that's all.
No, what? Small percentage of what?
Yes,
Splenomegaly.
Epidemic.
yes or no, that's all.
Okay.
Hodgkin's, do you find it or no? Yes or no?
yes, sir.
Confusion.
Dr. Thomas, I think, I read SRV sir's book every day like Bible. I don't touch Bible. I don't read Bible, but I read his book every day for taking your class. I think it is high time you start reading his book. It's very simple question. It is all over the world, people. It's very simply written in that point, in that Hodgkin's ka chapter. It's just written 1, 2, 3. It is written splenomegaly, very common. Hepatomegaly common. Non-Hodgkin's disease. Splenomegaly not common, but hepatomegaly common. It is written like that.
Next question will be obviously asked how to differentiate between a kidney and a spleen.
Yeah.
So I hope you should, because we are again not going to discuss it because there are
Yes,
different
yes.
factors between
Yes.
palpable kidney and palpable spleen. So you should be able to
No.
state the differences.
Now, Ritu, this you said left side supraclavicular lymph node. You said quite big. Is it virtuous node or something else? Is it medially located, middle of the supraclavicular, laterally located?
Laterally located.
Laterally located. You said node or nodes? It is. You have put nodes.
Oats.
Node. You said surface firm, surface smooth. You said matted also somewhere.
Or matted also
So
we
not
heard, yes.
Not matted or matted?
Not matted.
Not matted.
For it to be not matted, it should be more than one, no?
Yes, sir.
Because I thought you mentioned only one.
Single node?
Yes.
Single node, he said. Okay. He said it's firm, it is not hard. So next slide, Shreya.
Just what Keshav sir had said, please note for all students, you should know the 7 differences between how to differentiate a left kidney from spleen. Of the 7, at least 5 you should know. That is based on the site, extent, inspection, palpation, percussion. That's all. It's very easy to remember all this 1, 2, 3, 4. That's all. It's very easy.
Ritu, here, percussion, always liver donor should come first. That is the basic, there is a guideline. So you can't put that on last. Always mention percussion when you present. It starts with the liver donor. Should automatically.
Span is also important.
Yeah.
Span will tell you what is the size of the liver. No, it starts in the 5th intercostal space, agreed, but till where it extends, that is pretty important.
Always start with the liver dullness. Percussion, abdomen, liver dullness. Otherwise, there is no guideline. This is the guideline, basic. Then we go with the percussion over the mouth. Then for the free fluid. That is the order. That is not exactly order. Okay.
Again, when you percuss the left hypochondrial mass, then you should be able to tell the size in centimeters because it is extending from 9th to where the border is. So the centimeters is very important. Then you can easily say this is massive splenomegaly.
How far percussion dullness extends is very important because percussion is the most important thing in the abdomen. See, anterior abdomen, whatever comes in front of the bowel is dull. Whatever behind the bowel is resonant because the bowel is there in front. Whatever from the bowel, it is probably impaired resonant or impaired dull variable. Understood? So, very crucial clinical method is percussion to place the mass where exactly it is, whether it's in front of the bowel, behind the bowel, from the bowel. Understood? So, this is very important. Percussion is should not be neglected. It gives a lot of information. Understood? Always you start with the liver dullness. It's the basis. It should not come at the last. Okay? So, it is dull, she said. I will agree with that. So, next slide. Here, next slide. Auscultation is said genitalia, correct like the not done. What you wanted to look for in PR?
Sir. Sir, I didn't hear you.
Auscultation. What do you want to hear?
digital rectal examination.
In case of any splenic bruise, splenic infections, splenic bruise may be heard.
So that's a rectal
Infarction,
examination.
infarction, there is no blood supply. No, why
No
will
blood
you hear
supply. Why
bruit?
you will get bruit?
Bruit. What is heard in the spleen? Bruit or something else?
Clinic rubber or sonic
Rub.
bruit.
Rub.
Splenic rub.
Rub.
Rubber you look for, not bruit. If bruit is there, it may be in the epigastric region for portal hypertension. There are so many syndromes are there, signs are there. That's a different thing. You can read it. Why rectal examination you want to do?
In case of any secondary malignancy, malignancy.
Again, Robin is worried. Secondary, if you tell why. Uh, so, uh, why rectal examination in this patient? Just what justify? Because in abdomen you have to do the rectal examination. Not get much information if you are thinking in terms of lymphoma. Okay, so what it is for completion you have to do. Okay, malignancy you are thinking of splenic secondary is not that easy to think. Somebody with a clean, firm clean will not think of splenic secondary clinically. I think. Uh, Understood. So, okay, next slide. So this is already we have told which size, everything we have told. Spherical is said mobile, no fixed to skin, no fluctuation is said, no other lymph nodes. You examined axilla,
Yes, sir.
you examined other neck. Have you examined
Yes.
oral cavity in this patient?
Oral cavity, no, sir.
Inner
There
wall
should be
tearing,
focus.
tonsil,
Walner, mm, yes.
oral cavity. Once you thought your clinical provision diagnosis on history, you should lymphoma. If you thought you have to examine oral cavity. Inner wall tearing you have to check. Epitrochlear lymph node you have to check. Operator lymph node you have to check. Sternal tenderness you have to check.
And you should mention that you have checked all these sites.
So all these things should come automatically once you thought of lymphoma. Understood? That's the features actually. So oral cavity examination is a part of the tonsil is a part of lymphoproliferative organ. The reticular system part of it. No, many conditions it may be involved. Understood? Lymphoma it may get involved, especially in NHL. So you have to examine that. Oral cavity examination is very important. Okay, and epitrochlear lymph node also. Okay, you heard about epitrochlear lymph node? No, commonly NHL it is involved. Sometimes syphilis it is involved. Sometimes rarely infectious nucleosis. But at our level, our point, NHL, epitrochlear lymph node. All other rare conditions you can forget. Syphilis is uncommon now. But first thing you have to think of is NHL. That's crucial. For that, you have to examine both side epitrochlear lymph node. Okay. So other palpable lymph nodes is not sufficient. You have to specify these are the things I want to look for. And just bone tenderness is not sufficient. Sternal tenderness is very specific because it says it not only says it is lymphoma, it also says it's the stage 4 disease. Bone marrow is involved. It's clinically relevant because bone marrow is involved. Okay. That's why all those salient features you have to mention. Once you think in some stage of your clinical examination it is lymphoma. Okay. You should correlate and go along with that line actually. Okay, so go to next slide, Robin.
Yes.
She said respiratory system, central nervous system, sensory system. Okay, skeletal system. You are told bone pain, bone tenderness, tunnel tenderness. You have to specify actually, always. Okay. So next slide, Shreya. Okay, summary. She told specific. You are told pallor, hypochondrial, sagittal, splenomegaly, all the things you are told. Next slide. You said lymphoma, you are not specified which lymphoma. Clinically, you should be able to tell what type of lymphoma. He should at least give a clinical diagnosis, not just lymphoma. What type of lymphoma? Probably what is the type in this case? Neck lymph nodes are in is not.
I, I think this may be a type of Hodgkin's lymphoma.
You can always specifically clinically tell. It's a clinical diagnosis, clinical lymphoma. Eventually, may confirm.
And when you write this diagnosis, it is a case of a left hypochondrial mass. Probably no. Why is it suggestive of enlarged spleen? You have something else to suggest? Is it coming from splenic flexure of colon, left renal system, stomach, left lobe of liver? Is it suggestive of anything? No, right? Pakka, it is splenomegaly. So
Yes.
there's no point of saying suggestive of anymore. You
Yeah,
use such words suggestive, probably, when it's a malignancy. You have a case of a right parotid swelling, probably pleomorphic adenoma. We don't know histopathological diagnosis. Then associated with palpable left supraclavicular lymph nodes. Why palpable? What is the significance of that word there? You have left supraclavicular lymph nodes. That's all. It is palpable.
this is not
It's not
suggestive.
like an axilla where it is not suggestive that we are not sure.
You have confirmed clinically what it is. So
Okay.
clinically you say it is splenomegaly. This is just splenomegaly, case of splenomegaly with the left supraclavicular lymph node, probably lymphoma. So all other things are
Probably
not
lymphoma.
probability. It is a clinical finding. We have agreed, everybody agreed, you have accepted it. Okay, you can always put like a probably Hodgkin's lymphoma. As
Yes,
a,
probably Hodgkin's
in
lymphoma.
specific. Okay, then it will come.
What
to
are
the,
what are the
What-
points to suggest that it is Hodgkin's lymphoma? What are your points to favor the diagnosis? Because we are at 9 o'clock now, so
Yeah,
Hodgkin's
and
lymphoma mainly presents as a bimodal peak. Here, the patient is a young age patient. Then
okay.
patient is having splenomegaly. Splenomegaly is most commonly seen in Hodgkin's lymphoma. Then patient is also having fevers and
hold.
fevers.
Okay, fever which is low, intermittent, low grade fever, etc., which has been there for some time. Any specific type of fever that you see in Hodgkin's lymphoma?
Bell Epstein type of fever.
Well, Epstein, can you describe what is this type of fever? Is it like this low grade, intermittent, relapsing, remitting, this sort of thing, or?
It's a cyclical type of fever wherein the patient will have um, a rise of temperature and
Fever, rise of
on and
temperature
off
is there.
fevers will be there, but over a period of 1 to 2 weeks.
Okay, next. Okay, fever. Age, you said age, bimodal presentation, that is extremes of age, unlike non-Hodgkin's lymphoma, which is middle-aged and elderly population. 2, okay, splenomegaly. 3, fever. What else? Why do you suggest it is Hodgkin?
Cervical,
Cervical lymphadenopathy.
significant cervical lymphadenopathy, agreed.
Then here there is no involvement of any Walde's ring lymph node, so it is not Hodgkin's lymphoma.
So these are your points to suggest. On what is the consistency of your lymph node? Your
A
supraclavicular
rubbery
lymph.
Inconsistency.
India rubber consistency. Okay.
Actually, she has put, I think, somewhere I saw a slide, rubbery consistency.
Yeah.
That is specific spleen with the neck lymph node, which is significant, which is rubbery, firm.
Okay.
First thing comes in mind with the fever, young age group. First thing should come is the lymphoma.
Is it mobile, ma?
Yes,
Is your
sir.
lymph node mobile?
Yes, sir.
Mobile. Form consistency is rubbery throughout. The entire lymph node is rubbery.
Yes, sir.
Okay. Hey, what is be specific?
Be specific. You should use some sense. You may be a confusion, but once you say this is lymphoma, no, then boldly tell it is rubbery, sir. Nobody will question you. So you should be very careful. You should be very logical. Okay.
Okay, sir.
You have told it is lymphoma, then you have to tell it is rubbery. Enter it is rubbery and keep quiet. Okay.
Okay, sir.
So applications are important when you have a clinical discussion. Okay. Right. So next thing. Next thing. So you said investigation, routine, ultrasound. What is that routine investigation?
Including blood investigations, including hemogram, WBC count.
Peripheral smear is important. Okay, that's it. Peripheral smear in any lymphoma gives a lot of added fine informations actually. Then of course, excision biopsy is the ideal thing. FNAC initially to have a initial screening idea of the lymphoma. Okay. Then entire lymph node has to be removed because you should do a tumor marker. Typing is important. All those things are which type. Additionally, tumor marker to say stage. All those things are important. Any additional imaging you want to do?
Ultrasound abdomen.
Okay, great. But currently, ultrasound abdomen, liver function test, and CT actually. Current standard is CT neck and chest. Add on to the abdomen. But Other lymph nodes also properly will be able to identify through CT, which are clinically not palpable.
Yes, sir. Very correct.
So CT, neck, chest, abdomen is also important. So treatment, because we are not going to discuss because of the time factor. Lymphoma is a main question for you. Clinically exam will discuss. Neck lymph node, three conditions you have to remember: lymphoma, tuberculosis, secondaries. These are rubbery, firm, precisely lymphoma, age group, splenomegaly. That who get towards the lymphoma. Fever, only lymph node. Additionally, tuberculosis has to be also thought of. Then second is if it's a hard lymph node with the fever, tuberculosis, then primary maybe somewhere else, maybe lung, because supracortical lymph like that. So thinking process should go like that. So three conditions always you have to keep in mind. Lymphoma, tuberculosis, secondaries. Then which is suitable, which is correlative, then give a diagnosis like this, it is Hodgkin lymphoma because of the age and all other factors. Okay. So Hodgkin lymphoma is a main question for you. Then examination, all other things, findings like Robin told, different staging systems are there. What is the staging system? Unarmed system. We are not going to discuss, read it, but it's important. A, B, C, D, Y, S is added for currently now. Spleen is very, very important organ, very commonly involved, although this is what Robin told, commonly involved. So, although differences between NHL and H, which is preferred, HL is better or NHL?
HL has better prognosis.
So what's the treatment? Do you think it's a which stage it is? Suppose imaging wise, only one is involved. Excision wise,
Stage 1.
Stage 1. Okay. Stage 1, yes. Comes. Okay. Stage 1, yes. So, what is the role of bone marrow biopsy in this patient? Which bone marrow you will use for biopsy? Bone marrow aspiration and biopsy, both they will do now. Aspiration different, biopsy different, but to single sitting they will do. Which bone marrow biopsy or aspiration you will use?
Which anatomical portion?
Which bone is used for bone marrow aspiration and biopsy? I'm asking a simple question. I'm not asking anything newer thing or which we are also not high-tech question. It's not a high-tech question. It's an application question. Usually, iliac crust is used currently. Olden days we used to do sternum. Now it is switch low to the iliac crust. They'll do both aspiration and plus biopsy. Okay. Aspiration is mainly cytological study. Biopsy is for histological. Okay. So both is done in the iliac crust under local anesthesia. Usually hematologists they will do, or pathologists themselves they will do it. Okay. So that is the point you have to remember. Bone marrow is an important role for lymphomas, and tumor markers are very, very important. Entire lymph node removal is important. Biopsy when you do. FNHC has got limited role, even though may be used initially as a screening purpose, not as a final investigation. So CT is the current imaging method, which is essential for lymphoma. P smear is very important. You have not mentioned that. It's the most important thing that, like Keshwar told, blood in the blood. Okay. So if it is a stage 1, what's your treatment?
Chemotherapy.
Hodgkin's lymphoma. Hodgkin's lymphoma, stage 1, stage 2, stage 3, stage 4. Stage 1, stage 2, what do you want to do?
Primary treatment. There is no surgery, am I right? Lymphoma. Other than excision biopsy, currently no surgery. Staging laparotomy is not used now. Splenectomy is not used currently. Okay. Olden days we used to do that's a different thing. So what's the treatment in this patient? You got a patient, you evaluated everything. Just a single word. Treatment strategy.
Sir?
Treatment strategy in this patient.
Chemotherapy regimens.
Okay. No. Hodgkin lymphoma stage 1 and 2. Robin has given the clue. Primary treatment is radiotherapy. Additionally, you can give chemotherapy. Whereas stage 3 and 4, it becomes chemotherapy and then radiotherapy. Where bone marrow, when it is involved, you give radiotherapy to the bone or spine. Whereas NHL main treatment is chemotherapy. Chemotherapy when there is a spine is involved or brain is involved, like that. Understood? Whereas HL primary treatment is radiotherapy. NHL primary treatment is chemotherapy. We are not going to discuss which regime, although you can always read. It's there in my book. Table is there. But the application concept you should remember. Understood? So here stage 1 you said primary treatment is radiotherapy. Of course, you have got a different method, all those things that you can always read. So, and differences between HL and NHL, all those things also very important. Okay. So next slide, Shreya. So chemotherapy you have put first. Okay, radiotherapy first comes. Chemotherapy, conservative, not conservative management, supportive management. It is pain, blood transfusion, all those things. Granulocytes comes down. That tells you what to add on to all those things. Okay, that's a different thing. Okay, next slide. Say next slide. Okay, so that is a Robin. 2 minutes he has presented well. This is a difficult discussion. Mass abdomen is always a difficult one. Before conclusive remark, sir, I'll just go through my slide very quickly in 5 minutes.
Yes, sir.
Each one of you have a conclusive remark. Say my slide. Go
Sir,
through.
I think we'll give the honor to Keshav sir because he's first time after we have come. So I think
Keshav will give the conclusive
let him
remark.
let him fire the first volley. After that, I will fire.
Yeah, that's right. I think. Yeah, my slide quickly. I'll go through that. And Keshav will take over for the conclusive remark.
Yes, sir, Keshav sir, please.
Shreya.
Keshav sir, your points on her presentation. Anything to add? Yeah.
I think defended almost all our questions well. She was prepared well for the presentation, but I think for a long case, I think you should need to write a little more in the sense that, like I told you, there are a lot of, you have to give an accurate description of the mass. The main question is mass abdomen. The most of the marks will be given to description of the mass. So that has to be a little more elaborate so that how you have examined, that gives you a clue that you are going to which organ specifically. So it is important for you to describe the mass a lot better than what you have done. But you have defended most of the questions fairly okay. Only thing is, again, then in which case sometimes the examiners might ask you to demonstrate one or two signs, how exactly you palpate the. So it is important that when you go next to the patient, how exactly you maneuver, how you palpate the abdomen of the patient. So you should be prepared for those things when in the long case.
That's absolutely right. Clinical method, how to demonstrate. They will ask now. Current MNMC guideline is like that. You have to show how to examine.
It may come as a part of the OSCE also, examine the spleen of the patient.
Right.
Liver of the patient.
Yeah. That's what you have to know, how to examine spleen, how to examine for liver, all those things also, other than these discussions. Okay. I will go through my slide, then Robin and Sir will have a. So, examination mass, this is, Shreya, next slide. Shreya. So I'm not discussing just differential parietal swelling, all those abdominal wall masses. Abscess is quite common. And intra-abdominal retroperitoneal masses we discussed, splenomegaly, in that malaria color, splenomegaly, ATP, anemias, lymphoma, for rare thing, clinic cysts. Clinic fracture colon, that's the next possibility. This will be discussed because it is impaired and does not move with the respiration. The bowel symptoms. So you have asked bowel symptoms in this patient. Tailor pancreas and pseudocytic tailor pancreas mass as such. That's what Robin discussed in between. Left subsplenic space, left kidney, hydronephrosis, renal cell carcinoma, polycystic disease in the kidney. 3 conditions you have to remember in the left kidney. Commonly, as UG is considered. Hydronephrosis, polycystic kidney disease, usually bilateral, left RCC, left renal mass. And of course, it is bilateral, bimanually palpable, vertically placed, moves in the respiration. Renal line will become dull. Normally, it is resonant, and we have got a band of resonant in front. That's the point to say it is kidney. And left adrenal gland tumor is a very deeply placed, not moving in the respiration, and not bimanually palpable, not bilateral. It crosses the midline. Adrenal gland for a specific reason they cross the midline, whereas kidney usually will not cross the midline. So the differentiating features which you have to remember. The different masses in the left may come across. Next slide. So I'm not discussing about the spleen because we are main focus in this case is spleen actually. So all these points you have to remember. Normal size spleen. Normally it is not palpable. Remember it has to enlarge 3 times. All the things are there in this slide. You cannot insinuate your finger. Maybe smooth form. Uncommon to have a nodular spleen. Don't tell it's nodular and then it's spleen. Upper part is not felt. Important. I can see to the right side. Hook sign is a very commonly asked question. Hook sign is very specific for spleen. You usually elicit from the left side. And spleen is dull on percussion. Remember, I have already told percussion. Next slide. Share next slide. Next slide. Next, continue. Method 1. These are different methods. Method 2, how to palpate from the right side, from the left side. Hook sign, changing the position. towards towards the lateral position. Left up. Next one. Next one. Share next one. So these are different methods from right and left. You can both sides. Initially, you have to start with exam from the right side, then from the left side. Next one. So different methods are there. So you have to know that standing position important. Again, from the left side of the important. Always begin always from the right side. All abdomen mass should be examined from the right side initially. Then you can change for specifically for the left kidney and spleen eventually. So next slide. I'm not discussing about these things. You can always go through. Hook sign is very important. Next slide. So this is what you are told. Middleton maneuver from the left side. Put your hand on the left side chest. Then ask the patient to take deep breath. Next slide. So surface marking of spleen is important. Again, see how exactly it is. Here the anterior and the superior part water notch is there. Separate from these by the ribs. These are the different surface markings for the spleen. Next slide. So causes again, I am not discussing congestive malaria. Portal hypertension is important surgically. Then IPS is important. Lymphoma is very important. And massive spleen, chronic CML, massive spleen you will have. Other conditions are myeloproliferative, typhoid, or the clinic tuberculosis. Nowhere lymphoma comes out. Nowhere primary malignant tumors, very rare, neoplasm. Okay. When you say malignancy, it's a lymphoma actually. Next slide. So hypersplenism is a word which you have to remember also. Overactive splenic function, which has nothing to do with the splenic size. Will be typical feature splenomegaly, pancytopenia, hypercellular or normal bone marrow, reversible splenectomy. So these are the different meanings for the exactly what the meaning of hypersplenism. Hypersplenism and splenomegaly is not different. Hypersplenism is the functioning part of the splenomegaly is a anatomical part, size. So that's a difference actually. Myelocystis is a different thing causes for that. Next slide. So we have exactly different methods to examine hook sign, right side, with this one from the left side to it examine. From always start from the right fossa, remember. Next slide. Next slide here. So next slide, keep on running. So this is the Hackett's grading system for the spleen. You can go through my book, it is there. 0, 1, 2, 3, 3, next one for the pink symbol, so large to the right side. So 1, 2, 3, 4, 5, also the next slide. So this is the one, next slide here. This is the one we have discussed already, Robin discussed, mild, moderate, severe. 3 to 8, more than 8. This is the grading. This is the enlargement. So for the spleen, just remember, clinically important. Next slide. So splenic mass and renal mass, I'm not going to discuss. Chronic band already told. Difference is important. In the exam, they will ask why it is not kidney, why you said it's spleen, what are the differences. So this table will help you to understand this thing. Okay, next. Renal angle examination is important. Sitting position, percussion. Normally renal angle is resonant, which contains colon, right side ascending, left side descending. There's a dull on percussion when kidney is enlarged. Kidney enlarged downwards, deflecting the colon medially. Next slide. So trough space, sometimes they will ask, is the trough space and Castle sign where it is dullness will appear. One spleen enlarged here. This is the lung part, 6th rib and 10th rib. This area normally is resonant by the stomach, but it has become dull by so many causes, by stomach mass, splenomegaly, or pleural effusion here. So trough space will come into the discussion when you present mass like this, where it is located. You should be able to surface mark the trough, which is the surface mark of the trough there. This is there in my clinical method, current edition, 4th edition. Okay, next slide. So I'm not detailed about these things. Next slide. So you should know about features of left colonic mass, left kidney mass, tail pancreas mass, retropetal mass, left adrenal mass. These are the different masses which come across in the left hypochondrium. So remember, it's very, very important. Okay. So all these things are there in my clinical method surgery and manual surgery to examine all the typical differential, everything there in the table. And next slide. Neoplastic mass, inflammatory mass. Which was rightly pointed to beginning in history told. They got a specific features, guidelines, clinically, it is inflammatory. So that's how we classify actually. Same modes. Next slide. So my book, Ritu, I subscribed to my website. If not, subscribe it and see my daily lectures briefly. And tell your friends, ask them to Blackman to subscribe my website. It's also important. It's free also, don't worry. And my manual of surgery clinical book, probably you are reading. If there is any comments put on that, I'll be very happy. And this is QR code for my website, and you have presented well. Definitely better than a UG level. I think there are shortcomings that is there anyway. It's the learning process. Don't be worried. Otherwise, done well. Good. So again, request everybody, Ritu, tell your students to subscribe my website and get my clinical method in surgery, and it got a video also for every examination video. Master examination is there video. All for examination is there in the video. You can always go through that. My manual, of course, with a very description for everything management aspect. Sir, Manohar sir and Robin sir, final brief conclusions.
And Thomas, you did well. Did well,
Definitely.
but only thing you had a spleen and you had a lymph node. Only two things you had. So that description of that spleen in toto and lymph node in toto will be suffice. So you gave a lot of so much information, but few points missed here and there. That's okay. But remember that you have only two things to argue in favor of your diagnosis. One is the spleen and other one is the lymph node. So both has to be completely explained.
Yes.
Otherwise, it's the overall thing is very good. Thank you.
Very nice, sir. Robin?
Dr. Thomas, I think the seniors have already given their comments. So the left hypochondrial mass is not a UG case. If at all the small spleen is, it's a postgraduate and DNB discussion case. So you have done very well. Despite that, we understand this. So don't worry. You have, like sir, both the three sirs have said, you have fielded the questions properly. Silly mistakes here and there, but that I think we can match up.
You have presented because it is a postgraduate, because sometimes we discuss postgraduate level. But like Keshav told, basic clinical methods, orderly fashion, that is same for UG and PG, whoever it is, clinicians or learners also. That orderly fashion, methodology, that is the foundation. It should be proper. Okay, so that's what we have discussed. That's what we wanted to highlight with you and other students who are listening. So that you have done well. You understood also most of the discussion well. Read regularly, that is important. Surgery is very easy to understand, much more easier to forget. Very, very evaporative subject. If you don't read, you'll forget next day. When Robin says, you feel very nice, very easy it is, very simple. But next day, when Robin sir asks, you won't be able to recollect and reproduce and tell him the right answer. That is a surgery, okay? Surgery is a difficult subject. Understood? It's a judgment, principle, discipline, courage. These are the four components of surgery. Understood? So all these things, of course, Robin is having sir note that, senior sir, professor is Keshav also a very well skilled person is, I know. So these are the things that which is very essential for surgeon. Okay, clinical methods are the pillar of surgery. That's the point. It's very, very important. You take decision by clinical methods. What exactly all these professors, seniors are telling. Okay, so you did well. Do well in the exam. Okay, keep in touch. And don't be worried. You are done well. You are through with the distinction. Okay. So thank you, sir. Manoharan sir, Robin, thank you very much.
Thank you, sir. Thank you.
Thank you very much for joining. Hope you'll join regularly. Sir, you are part of us. Robin, you are always part of me. You go out. Okay. Thank you, Robin, for
Keshav sir, it is nice meeting. I hope to see you next time also. I hope to see you when I come to Mangalore. I'm not yet come to Pondi. For the exam, I'll come. I'll meet sir.
Sure.
Ritu, Pettanu Poko hostel, I've informed the students there to stand by the warden. You have to run and fly. Yeah.
Thank you, man.
Pack up quickly. Yeah. Thank you. Very good. Yes.
Thank you.
All the best.
Thank you, sir. Thank you, Robin. Thank you.
Thank you, sir.
Thank you.
Yes. Thank you.
Thank you again, IT people, Shreya and Benny and Aditya and Abhinay here. All of the
Ritu, off you the Poko because we'll finish off with the Poko. There's no time. It's already.
Thank you very much. Good luck. Thank you. You carry on. Ritu. Thank you, sir. Thank you.
Thank you, Robin, sir.
Thank you, Keshav. Thank you.
Thank you, sir. Thank you, sir. Thank you.
Thank you, sir. Good night, sir. Good night.